All right, good morning. This is Matthew Menendez with White Plume. For those of you just joining, welcome. Let's go ahead and get started with our webinar. I want to make sure that we are able to end on time today. We've got a lot to cover. There's a lot that's going on, a lot that changed in the MIPS final rule. So I want to walk that through with you today, talk about some of the changes, talk about how to be successful next year, hopefully answer some of those questions. Let me show you what I hope to accomplish over the next 45, 50 minutes. We're going to start with some of the changes in the final rule. And the good news is many of the changes that were made are helpful. They make it easier for practices, easier for physicians to be successful in this new MACRA MIPS world. Okay? Let me walk through each of those to show you a little bit about what they mean. The first one is they heard your call for action, that other people need to be excluded from having to participate if they're low-volume clinicians, right? So we're going to talk about that. Who's excluded, who needs to participate, who has to participate, what that looks like. We're going to walk through that and look at what an eligible clinician is. That's a new term that's evolved from the old meaningful use term of eligible provider. They are now eligible clinicians. The next thing that was changed in the final rule, another big change, was a lot of flexibility was added. 2017 is deemed a transition year, and the government's really going out of the way to try to make it really, really easy to participate, to give you lots of options as far as how you want to do that, right? And to try to make it as easy as possible to avoid a negative adjustment, to avoid a penalty. Even practices that don't have an EHR are able to participate and avoid a negative adjustment during this transition year. So we're going to talk through that. We're going to show you what that looks like and how to be successful in that MIPS world. All right. The first thing that we're going to do, again, trying to lower everybody's blood pressure, is show you what you need to do if you want to just avoid that negative adjustment. If you just want to make sure that you don't see that penalty, right? That's what we're going to walk through, show you how to do that. It's very, very easy. Again, you've got options as far as how you want to accomplish that. But there may be others who want to do a little bit more, right? Who want to more fully participate in MIPS in 2017. And so we're going to back up and try to give you some information that's helpful in how do you make those strategic decisions. What's the government trying to do with MACRA? What's the big picture? Where are we headed down the road so that you can make good decisions on, do I really want to go this far? What is this really going to look like for me? And then I'm going to try to, again, leave plenty of time for questions and answers at the end. So if you're just joining us, welcome. Use that questions panel for any questions that you have. I can't promise you that I'll have the answer to every single one, but I will do my best to get as many of those answered as possible. Okay? So that's what I hope to accomplish in the next 45 to 50 minutes. So let's look at some of those changes in the final rule. Who has to participate, and what's the flexibility that we have in the transition year for 2017? All right, here's who must participate in MIPS. The final rule defines eligible clinicians as anybody that is a physician assistant, a nurse practitioner, clinical nurse specialist, or clinical nurse anesthetist. Right? Those are all eligible clinicians. Who does that not include? Well, your PT, your OT, social workers, they will not be considered MIPS eligible clinicians for 2017 or 2018 for sure. That's something that may be reevaluated for 2019. But that's who's a MIPS eligible clinician for this coming year. Now, even among the eligible clinicians, there are some people who can be excluded, who don't have to participate. Number one, so physicians that are in their first year of participating with Medicare do not have to, and in fact cannot, participate in MIPS. Same thing for low volume providers. And this term was expanded in the final rule that allows more people to not have to participate in MIPS. So if you see fewer than 100 unique Medicare patients, you do not have to participate in MIPS. You cannot participate in MIPS. Or, it's not an and, it's an or if you have less than 30,000 in Medicare allowed charges, then you do not have to participate in MIPS. You cannot participate in MIPS. The other people who will not be participating in MIPS are those that are going down the APM track, right? There are two tracks in MACRA. You've got MIPS and you've got APM. The APM is really the evolution of the ACO program. If you're going down that track, you're already aware of that. You should be well down that path. And there will be, by Medicare's estimates, there will be between 7 and 8 times more physicians that are participating in MIPS than APMs. So the vast majority of you are going to be headed down that MIPS track unless you meet one of those exclusion criteria on the first year or low volume. Okay? So that's who has to participate. That's who has to participate in MIPS. And that's one of the changes that the government has made in this final rule. The big change that you've probably heard about is what CMS is calling pick your pace. Now, when the proposed rule came out, we knew that there were going to be winners and losers. Based on how you scored in MIPS, you would either receive a negative adjustment or a positive adjustment, and that you were going to have to participate for a full year, beginning January 1st, 2017, and that caused a lot of stress for people. How am I going to do that? I don't even know what it is, and that proposal wasn't going to be out until October, and we're going to have to turn that around and start in January. And the government heard the stakeholders on that and allowed for some flexibility and allowed for particularly some of the smaller practices to give them a way to participate without having a negative adjustment in that first year. So let me explain what pick your pace looks like, because they've given us more flexibility and more options than what we originally thought of. And one of the options this year is very easy. It says submit something. Submit anything. It is a very low bar. And if you do that, you won't receive a negative adjustment. I'm going to show you in detail what those requirements are, but I want to just calm everyone down a little bit from the beginning. For next year, it's very easy to avoid a negative adjustment. That doesn't mean that everyone will do it, but it's very easy. It's a very low bar. Much easier than what we've been doing in meaningful use. I'll show you what I mean. So that's one option. Now, there will still be some people who do not participate. And if you do not participate at all in 2017, then you will receive a 4% negative adjustment. Okay? But the only way you'll get that negative adjustment in 2017 is if you do not participate at all. If you want to submit something, you will avoid the negative adjustment. Now, if you want to do a bit more, right, if you want to more fully participate in MIPS, you can do that. You can do that beginning on January 1st, 2017, and submit data in all of the categories and go for what Medicare is calling a moderate positive adjustment. All right. Now, you won't see that these payment adjustments don't happen until 2019. The performance year is 2017. The payment year is 2 years out. That part has not changed. But Medicare is also offering an in-between option here. It says, you know, I can do a little bit more than just submitting a minimum amount of data. I can more fully participate in MIPS, but I can't do it for the full year. We're not going to be ready in January. They have allowed for a 90-day partial year submission in 2017. That's what makes this a transition year. You've got flexibility in how you want to participate. It's very easy to avoid a negative adjustment, right? And if you want to do more, you may be eligible for what the government's calling a small or moderate positive payment adjustment. And we'll walk through this. We'll get through that at the end, but the dollar amounts there are going to be pretty small, right? The dollar amounts there are going to be pretty small, right? So these are your options. This is what kind of flexibility you've got in 2017. So just to kind of take one step further down the road, what does it look like to submit something, to kind of test the system and avoid that negative adjustment? Let me walk through what you have to do and what your options are there, because you've got options within that category as well. If you want to avoid the negative adjustment in 2017, you can submit one quality measure. You can submit one quality measure for the whole year at any point during that year and avoid a negative adjustment, right? A lot of the quality measures, I'm going to get into some examples of these later, but the quality measures are very similar to what we've been using for the past couple of years under PQRS. Or you can submit one improvement activity, right? Things like extended office hours, right? Engagement with new Medicaid patients, participating in a CAPS survey. You can do one of those improvement activities, and you've got a long list to choose from. And that will avoid the negative adjustment in 2017. Or you can do the 5 core measures of advancing clinical information. Right? Now, those 5 core measures, that category of advancing clinical information, that's what used to be meaningful use. Right? Meaningful use is gone. We're now doing MIPS. These components are what used to be meaningful use. And the 5 core measures in this category are e-prescribing, patient access, right? Security risk assessment, send a summary of care record, right? Receive a summary of care record. And all of those are very, very low volume, right? So you look at the e-prescribing measure description, and it's just one permissible prescription written by the eligible clinician, right? It's a very, very low bar. So you may decide you want to do one quality measure, or you may pick an improvement activity, think that's a better fit for your practice in 2017, or you can do those 5 core measures, right, which are some of the easier things that we used to do under meaningful use. We're not talking about CPOE. We're not talking about clinical decision support. It's very, very basic. So we've got a very low bar here of what you need to do in 2017 if you want to avoid the negative adjustment. You do not have to start that on January 1st, right? You don't have to start that in the first half of the year. You can do this at any point in the year, submit something, and avoid that negative adjustment. Okay? So hopefully that relaxes everybody. It takes some of the pressure off. It says at least I'm not going to have a negative adjustment in MIPS. I'm not going to see that hit my financials until 2020 at the earliest, assuming that I can do this. Okay? That should be very easy for most of you. Even if you don't have an EHR, you can submit a quality measure. Even if you don't have an EHR, you can do one improvement activity, right? And if you do have an EHR, most of them should be able to handle those 5 core measures very, very easily. You're probably already doing that today. All right, so you've got some decisions to make. What do we want to do in 2017? What is my strategy going to be? And I want you to think about this, and I want you to really make a good decision here. It says, am I going to do just the minimum, right? Or do I want to do more? I think there are reasonable people who will make both decisions. You just need to make that decision with your eyes open, right? If I do the minimum, that's the least amount of effort. That's the least amount of change for me right now. I'll avoid the negative adjustment. All of that is good, right? And who knows, maybe they'll make 2018 a transition year as well. I think that's unlikely, but I didn't think ICD-10 was going to get delayed either. All right, so there will be people who that's kind of their thought process, and there will be others who say, you know what, I want to do more. I want to go for this positive payment adjustment, right? We think some of these things are not going to be that difficult to do. We think we're ready for this. We've been making preparations for this, and we want to get off to a good start. because we know that these MIPS adjustments, both the positive and the negative payment adjustments, are going to increase over time, right? The negative adjustment for 2017 is 4%, but that's going to grow up to 9%. And we want to take advantage of this as a practice year. We want to work on this. We want to work on our processes so that we're ready to be successful as the plan gets rolled out. And we're doing a lot of these things already in our organization today, right? I think you can make an argument for either of those cases, and you can probably make an argument for some of the things in between. But you need to make that decision with your eyes open, all right? That's what we want to do. Make sure that you're making a good decision and you're thinking strategically. All right, so if we're going to do that, if we're going to really think through this, we need to zoom out and really understand what the program is going to look like. What is the government trying to do? Where are we headed with all of this? All right. You know, most people know that from a big picture perspective, the growth in Medicare spending is unsustainable. And we've got baby boomers that are coming into that population every day, right? So we cannot keep going as we are. That's what MACRA was all about, right? MACRA repealed the sustainable growth rate, which most physicians loved. It got rid of meaningful use and PQRS and the value-based modifier, right? And tried to consolidate that into one program. And that's what we're rolling out with MIPS. And what the government is trying to do, what the payers are trying to do, is achieve the triple aim of healthcare. That is the big picture here. The triple aim is better care and lower costs and better patient experience. All three of those things at the same time. And Medicare cannot do that by themselves. They know that they have to engage patients in that process. They have to pull the provider community into that process. And you're seeing this transfer of risk from the payer to the patient, from the payer to the provider, to try to bring everybody to the table so that we can accomplish that triple aim. And there's certainly been some painful bumps along the road, absolutely, right? With patients having more of the risk, the way that that's manifested itself, and it's been in the news, and you've probably experienced this with your own health plan, we certainly have, is you end up with higher premiums and higher deductibles, right? Putting more of that financial risk onto the patient, right? And at the same time, trying to engage patients in their own health, right? Trying to make that information available to them through a patient portal, right? Requiring EHR vendors to share that type of information so that patients can manage their own data, right? That doesn't always happen. That doesn't always happen well. But that's what is trying to be done. You know, and on the provider side, on the clinician side, we've got this new quality payment program. That's what MACRA created. There are two tracks. We talked about that already. You've got these alternate payment models, which are like ACOs, more shared risk, more shared savings. And then you have the MIPS program where the majority of physicians will participate. And both of those are about making the shift from volume to value, paying for quality, paying for outcomes, paying for savings rather than paying for procedures, right? And that's a very complicated thing to do. It sounds very simple, but it's a very complicated program to try to make that shift and to do it in a way that takes care of the patient and engages them in the healthcare experience. Okay, so that's where we're headed. That's the big picture. And the way that that's structured in MIPS, let me show you what that looks like. There are these 4 categories in MIPS, right? And each one is weighted differently. And you can see those weights change over time. This is what the weighting looked like in the first proposed rule. And it changed slightly in the final rule. One of the other changes that was made in the final rule was that cost category would not be part of your MIPS score in the first year. Right? That was some of the flexibility that the government had, but it has to, by law, right, be up to 30% of your MIPS score by 2019. So unless Congress changes that, we know that it will be up to 30% by that year. So that 10% moved from the cost category to the quality category for your first year of your MIPS score. So you've got these 4 categories, right? And I'm going to talk through each of them and give you some examples of what those actually look like, what those will look like for 2017. But you put these things together, and that's what generates your score. So you can see the government priorities here. Cost and quality are the 2 biggies. They will always be equal to 60% of your MIPS score. You cannot score well in MIPS if you're not doing a good job from a cost and quality perspective, but we're going to spend time talking about that. Much of the improvement activities are about patient engagement and the patient experience, right? These are things like, quality and satisfaction information, reporting from patients, engaging Medicaid patients so that they've got access to health, extended office hours, right, so that patients can see their doctors rather than going to the emergency room. These are things that you can do without your EHR, right? Now the bottom category, that advancing care information, that's the old meaningful use, right? A lot of those requirements have been toned down, but you can't get any of those points at the bottom. You can't get any of those 25% of your MIPS score without your EHR. So I get questions from time to time about, can you do this without an EHR? Certainly. You can do cost, quality, and improvement activities without an EHR, but you can't do the advancing care information without it. Does that mean that you can participate in MIPS without an EHR? Yes. Does that mean that you can get the top score without an EHR? No, you cannot. Okay? So meaningful use is going away, but your EHR is still going to be very important. And so let me do this. I've been talking for a little while. Let me launch our first poll question. And so what I'm going to do is, I've seen some surveys like this before, but the question that we want to ask is, what's your current feeling towards your EHR vendor, right? We love it. We would never want to change, right? Well, it's okay, but the thought of changing to another EHR makes me want to pull out all of my hair, right? I don't have much left, but I'd pull out whatever's left, right? Too hard to change, costs too much money, and we're probably not going to like the new vendor any more than I like the old vendor. I hate it. But we cannot change. It may be outside of my control. I hate it, but I'm going to get a new one in the next 6 months, and some of you may not have one. So just pick which one best fits your practice. Right now, just to give you an idea of what the polling looks like, most people fit in that second category. It's okay, but we're not going to change it. It takes too much time, takes too much cost. That's almost 9 out of 10 people are in that category. So 87% right now are in that category, just to give you some feedback. The next one, there are about 8% that do not have an EHR, and 4% of you that say you love it and that you would never change EHR systems. So thanks. Hope that's helpful for you. It's kind of fun to have some engagement back and forth as we go. So here's what I want to do next. I want to drill down into each of these categories, show you what it looks like if you want to just get the minimum and get no negative adjustment, and what you'd have to do if you wanted to do more in 2017. Okay, so let's start at the bottom. We'll work our way up to the top. So the first one is this advancing care information, right? This is what used to be meaningful use. So you've got the requirements for your base score, right? So if you wanted to do just the bare minimum and you wanted to do it in this category, this is what you need to do. It's e-prescribing, patient access, security risk assessment, receive one transition of care and send at least one transition of care. Okay? That's it. Pretty simple. Right? If you want to do more, you certainly can. Right? We've got these additional measures that you can do. Now, you don't have to do all of them. The more of them that you do and the better that you do, the more points you will get. But it's not like meaningful use was. Right? It used to be all or none. You missed one measurement by 1%, you were done. You weren't getting your incentive payment. They have put a lot more flexibility into MIPS. It says you can choose which ones you want to do, which makes sense for your practice, what is worth the effort, right? So you can kind of gauge where you want to participate and how you want to participate. I think that's very helpful, but it means you need to be more strategic in your thinking, right? What makes sense for my practice? What doesn't make sense for my practice, right? That's the advancing care information spot, and 25% of your MIPS score comes from that category. All right, let's drill down into improvement activities. The next one. This is the smallest category, will continue to be the smallest category, but you've got a lot of flexibility here. All right, let's look at these improvement activities. If you want to fully participate in MIPS, you can either choose to do 4 medium or 2 high priority activities. Again, you've got some flexibility here, and you've got a long list of choices to choose from. There are 93 activities across 8 domains. All right, summarize these here for you. I'll give you some examples, but if you want a link or if you want a copy, I've got an Excel file that has all of them listed out so that you can kind of look through that. Happy to share that with you. Again, just let me know in the questions section, and I'll get those for you. I can send you the link or send you the file either way. But you look at this, you can start to see what the government's trying to do, what data they're looking for, how they prioritize that, right? And if you want to pick just 2, you can fully participate. If you want to pick just 1, you can avoid the negative adjustment, okay? So you've got some flexibility here. Let me walk through a couple examples. I think it's always helpful to see some examples of what these improvement activities actually are. So here's one in the beneficiary engagement domain. Right, this is a high-weighted activity, and it says basically you're trying to collect and follow up on patient experience, get satisfaction data from them, right, so that you can better engage your patients. Again, some of you may already be doing some of these today. Some of you may be wanting to do these and say this is a good opportunity for us to change the way that we do some of this with our patients. Here's another one, expanded practice access. This one gets talked about a lot. It says, you know, it's a high-weighted activity, right? And we're trying to provide greater access to our patients, right? And if you look in the details of this, you know, one of the examples that it gives is a protocol-driven nurse line with access to the medical record. Again, many of you may already have that. Another example that they give is that you're allowing for same-day or next-day access to your physicians, right, or to a MIPS-eligible clinician. It may be a nurse, maybe a mid-level, right? Again, some of you may already be doing this, and it would be an easy way for you to participate in MIPS. Here's another one, in the Achieving Health Equity. It's talking about Medicaid patients specifically here. And the details tell you it's allowing new and follow-up Medicaid patients to be seen in a timely manner. Right? This includes patients that are dually eligible for Medicaid and Medicare. Last one I'll share with you, patient safety and practice assessment, is if you're participating in your CAPS or another supplemental questionnaire. Right? A lot of different activities. You can see that there are over 93 choices. And if all you want to do is avoid the negative adjustment, just pick one. Pick the one that makes the most sense for your doctors and most sense for your patients, and do that. If you want to more fully participate, you can choose 2 of the high-weighted activities or 4 of the medium weighted activities. Again, I've got an Excel file that lists all of these. It has all the quality measures, all the improvement activities, all of the advancing clinical information requirements in one place. So if you'd like that in a consolidated way, you'd like that email file, that Excel file emailed to you, let me know. It's also available on the CMS website. Okay, so hopefully that starts to provide some color to what does it mean if I want to participate in advancing care information. What does it look like from an improvement activity perspective? That's the new one. Improvement activities is a new category. That's not something that we've been dealing with historically. All right, so those are the first two. Let's move to the quality component. This is going to be the largest area for 2017 and 2018, and then it will be equally weighted with cost from there on out. So let's dig into quality and take a look at what that's going to look like. This is very similar to PQRS. Most of you are probably familiar with this. Again, if you want to fully participate in 2017 during the transition year, you'll need to choose 6 measures, and 1 will need to be an outcome measure. Okay. Again, as we make progress through MIPS over the years, I believe we're going to move to more and more outcomes measures. When you think about what the government's trying to do, they're trying to pay for outcomes. They're trying to pay for value. That's what they want. Right? So they're trying to move us in that direction. Now, if you want to just avoid the negative adjustment, and the way that you want to do that through a quality measure, again, all you have to do is 1. And you've got a lot to choose from. There are over 271 measures. These get updated on an annual basis. Many of the specialty societies actually propose measures that are clinically relevant to their specialists. In that Excel file, you can sort and filter by specialty. So if you'd like to take a look at that, just let me know in the questions panel. I'll get that to you. But you have these 6 domains. And for those of you who've participated in PQRS in the past, these probably look familiar. There are other types of measures, but process and outcome measures are the 2 most common, so that you can get a feel for what you're choosing from. I'll go through 4 examples quickly, just so you can take a look at that and see what some of those examples might be. In the patient safety domain, this one's an outcome measure, right? What you're doing is, again, this should be familiar to many of you. It is the percentage of patients 18 years and older where we've documented all current medications in the medical record, right? That's it. That's what it is. If you wanted to pick just that one, you can do that and not get a negative adjustment in 2017. Another one is in the communication and care coordination domain, right? This is patients that have a care plan, right? They've got advanced directives. They've got a decision maker that's documented in the medical record, right? Again, anybody can do those. Those probably cut across specialties. And then there are others that are more specialty specific, right? Here's an outcomes measure for ophthalmologists. For patients that have cataract surgery, what percentage of them had improvement in visual field tests within 90 days of surgery? Right? That may be more appropriate for specialists to say that's the one that we want to participate in. That's what we really care about tracking and documenting and improving. And then in the orthopedic side, right, you've got this function and pain assessment for patients with an osteoarthritis diagnosis. Right? What percentage of my patients over the age of 21 that have a diagnosis of osteoarthritis did we document an assessment for function and pain? So again, you've got flexibility here. You've got lots of choices here about how you want to participate, at what level you want to participate, and then within those different categories, which measures make the most sense for my doctors and my practice. All right, so we've talked about advancing care information. We've talked about the improvement activities. We've talked about the quality measures. The last one is cost. The last one is cost. And this is the one that doesn't count for 2017. But I would caution you not to ignore it. Right? Here's what happened in the final rule. It's not part of your MIPS score. That weight has been taken, those 10 percentage points have been taken from cost and put into quality. But there's always a catch, right? And here's the catch. Here's the quote from CMS on this, that they're not going to calculate it as part of your 2017 score. But they are going to calculate it. They are paying attention to this because it's very important to them. It's going to be 30% of your MIPS composite score by 2020. And the way that they're doing this is they're calculating it based on claims data. They are using your claims data, and they have been using your claims data for quite some time to measure how cost-effective different clinicians are. They are comparing that data. They will continue to do that in 2017. It's just not part of your MIPS score yet. Okay, so I would say you need to think about that. The world is changing a bit. This data is very, very important. It's very, very valuable, and you need to be prepared for what the government is trying to do with that. Right? So when you look at these categories, right, there's a difference. The advancing care information is all about the technology that you're using and making data available. The improvement activities is really about patient engagement. But what the government is really trying to do with the triple aim is mostly about cost, and it's mostly about quality. Right? Those are the two biggies. Those will continue to be the two biggies. Right? If what they really want to accomplish is making the shift from volume to value. And so let me talk about that just briefly here, because it sounds so simple. The government says we want to start measuring and paying for quality, right? But when you do that, when you try to measure that, the pushback that you get from providers often is you don't understand. My patients are sicker than the average patient. And so the outcome for that patient is not going to be as good. And the costs for that patient are going to be higher. And what's happening with MIPS is the government's response to that is, okay, prove it. Okay, we get that. We understand it. We will make this risk adjusted for your quality measures, for your cost measures. But you have to prove it. You have to have the data to back it up. And here's how that works. Many of you have been on a webinar with me before where we've talked about HCC coding. We've talked about risk-adjusted coding. I can't give you the comprehensive version of that today where we don't have enough time. But I do want to walk through this with you just briefly because Medicare has been using HCC coding for risk adjustment since 2004. They have been refining that algorithm, and it does a very good job of measuring patient acuity and predicting future healthcare expenses. And that's going to be very important for your quality and cost scores under MIPS. Not in 2017, but going forward. And that's why you may want to think about the data that you're giving to the government in 2017. Here's how HCC coding works, right? It takes the demographics for a patient and the diagnoses for a patient and gets an HCC score. The sicker your patient is, the higher their HCC score. The higher their HCC score, the more expensive that patient is to Medicare or to any payer for that matter. So it's important what you code. Diagnosis coding becomes much, much more important as we make the shift from volume to value. It's not just about getting the claim paid. We still have to do that. That will not change. But what you code is much, much more important than before. Right? So when you look at that level of frustration, right? When doctors get frustrated that say, my patients are much sicker than the payers think they are. How do we explain the gap between those two realities? The difference is what you code. Medicare, the government, the commercial payers only know how sick your patient is if you tell them. And where they're getting all of that data is from your claims. Okay? So I want you to think about that and be mindful of that while we're making these decisions about how we're going to participate in 2017, what our processes look like. As we make that shift from volume to value, your diagnosis coding becomes much more important. In the old world, as long as we had a diagnosis that made a procedure medically necessary, we were good. That's what that diagnosis data was being used for. But as we transition to this new world, yes, it's about reimbursement. We still have to do fee-for-service, right? But we have these risk-adjusted MIPS categories for cost, and we have quality. That diagnosis coding is being used to calculate HCC scores, right? And we need to have that data, right? If I've got to engage my patients and manage patient populations, I need to have the data available, right? If I'm an orthopedic surgeon and we're trying to look at outcomes for total knee replacements, I need to know what percentage of my patients are diabetic and are long-term users of anticoagulants and are morbidly obese, have a BMI over 40, because my outcomes are going to be much different the sicker my patients are, right? Right? Then the other part, if we're trying to engage patients in this process, and they're trying to push patients towards the patient portal, that's where we have some problems as well. One of the things that I hear people say, it's difficult to get patients to use the patient portal. We know that, right? But when patients, let's say they do get in there, and they look at the diagnosis list, they look at the problem list in the patient portal, they say, wait a minute, that's not right, or certainly not complete. And what was happening for many people is they were putting in data just to check the box in meaningful use. They weren't really obeying the spirit of the law. They were obeying the letter of the law. And so when patients got in there and actually started looking at their portal, what they were seeing didn't really match up, and it made them think, maybe my doctor doesn't know what's going on with me, right? Which is not true. They were just looking at some bad data, right? So I'm curious. Let me launch my next poll question here. And the question is, when we're really looking at this, how would you describe the patient experience in your portal, right? As far as it relates to what they see on their problem list, on their diagnosis coding. Are all of my doctors, are we doing a really good job on that? Do you think the patient's really seeing a pretty accurate representation of all of their problems, right? Or they may be only seeing the primary diagnosis that they were seen for in that visit. Is that helpful for them? Is that something that they struggle with? Or some of you may not have a patient portal. Just to give you a ballpark of what we're seeing so far, the majority of you are in the good or fair category. It's about 40% each right now. And then single digits as far as excellent, poor, or we don't have a portal. Just to give you an idea, that's something that many people seem to be either struggling with, where they've got a lot of room for improvement, or they think they're doing pretty well, but they still have some room for improvement. Less than 10% of you say we're doing excellent at that, and that's in there for every single one of our patients. So thanks again for participating. That makes it fun, makes me feel like I'm not just talking in a vacuum here. So let me give you your diagnosis coding has the impact in all of those areas. And let me just show you one more example that I think is helpful to illustrate. Imagine that you have 3 identical patients. They're all relatively unhealthy, and they all need total knee replacements, right? But the first patient, you only code one diagnosis code. So to the payer, to the government, they look relatively healthy. For patient number 2, you're a bit more specific in that primary diagnosis, right? You're not using one of those unspecified ICD-10 codes, but you also code the comorbidity of morbid obesity, right? That's going to impact how well they respond to the procedure, right? And you're more accurately reflecting that patient's conditions. But the third patient, you're accurately coding not only primary osteoarthritis of the left knee and morbid obesity, but also the fact that they have type 2 diabetes with complications. That patient, you're accurately reflecting their condition. And you're going to see that reflected in the HCC score for each of those patients, right? Is patient number 3 more than twice as sick as patient number 1? No, they're identical. The only difference is what we've actually coded, and we've got to be careful about that, because that is used to calculate what the expected cost is for that patient. And Medicare expects to spend $6,600 more on patient number 3 than on patient number 1. And patient number 2, they expect to spend $700 less than the average Medicare beneficiary. So the data that we're providing really makes a difference, and I want you to be careful about that. So be mindful of the data that we're sharing with the payers, the data that we're sharing with the government. All right, I want you to think about that as we try to make the decision of how do I want to participate in MIPS in 2017. I know I want to avoid the negative adjustment. It's pretty easy to submit something. Is that the path I'm going to take? Or am I going to spend a little bit more time and share a little bit more data to really practice and get ready for when I have to do this in 2018? Okay? And let me walk you through this because it's a bit complicated. You're not making that decision in a vacuum. The way that other practices make that decision will impact your adjustment, particularly as we get out of the transition year. Let me show you how those adjustments work. I'm going to try to show you with a picture because I think that's a helpful way of doing it. For 2018 MIPS, everybody is going to get a score of 0 to 100. That's true in 2017 as well. But there aren't going to be that many people getting the negative adjustment in 2017. So everybody's going to get a score, and that score is going to be compared to your peers. Right? It's like back to college. You're being graded on a curve. Medicare will set the performance threshold, and everyone above that is available for a positive adjustment. Everybody below that is eligible for a negative adjustment. That's the way that it works. Now, you won't get that payment adjustment until 2 years later. So your 2017 score will impact your 2019 reimbursement. Your 2018 score will impact your 2020 reimbursement. And the higher your score, the further you are away from that performance threshold, the larger your adjustment. So if you get a 0, your negative adjustment is going to be greater than if you get a 10. And if you get a 70, your positive adjustment is going to be less than if you got a 90. Right? And here's the really tricky part that makes the math hard, is that the total adjustments have to be revenue neutral to Medicare. The total adjustments are revenue neutral to Medicare. That means this is not a government-funded program. They are taking money from the people who score poorly and turning around and giving that same money to the people who score well. So it's not just your score that matters, but it's the scores of your peers that matter as well. Let me give you an example. Simplify it so that that can really sink in with everyone. Let me give you an example. Let's assume that there are only 2 practices in the entire universe of MIPS. There's my practice, and there's practice A. Now, my practice, we did a great job. We got a 70 on our MIPS score. We were very, very proud of the work that we had done there. Now, practice A, they didn't do so well. They did not come to this webinar. They didn't do anything. They got a 0. And that means they got a 4% negative adjustment, and they're not going to be happy about that, right? Now, that 4% negative adjustment is what's available to pay the practices that did well. And the only practice that did well was mine. So that 4% positive adjustment is coming to me, and I really like that, right? All is good with the world. Now, let me introduce a layer of complexity here. Let's add in a new practice. Let's add in practice B. And they didn't do so well either. They got a 0, and they got a 4% negative adjustment. But guess what? Practice A got a 4% negative adjustment. Practice B got a 4% negative adjustment. That means that I get an 8% positive adjustment, and that makes me really happy, right? I didn't do any extra work. I didn't do anything different. The only thing that changed is that there was another practice that didn't do so well. Okay, but there's a flip side to that coin. Let's assume that practice B, this time, they do a bit better. They get a 70 also. And you know what that means? That means I can't get an 8% adjustment. There's not 8% to adjust. The only available dollars are from practice A, and that means they need to be shared between my practice and practice B. So what just happened? I didn't do anything different. I still got a great score, but there's less dollars available for me because of the change in practice B's performance. Okay, so you can see how other people's decisions are going to impact you in this new world, right? You're being compared to your peers. You're competing against your peers for this. It's a zero-sum game. Dollars will be taken from the losers and given to the winners. And there's one more area of complexity here. I'm going to do the last example. All right, let's assume I'm back to just two practices. My practice and practice A, I got a 70, they got a 0, and we get the 4% from practice A gets paid to my practice. Great. But you know what? We're not identical practices. They only have 3 providers. They only bill Medicare for $100,000. So that $100,000, 4% of that is only $4,000, right? Now they're not happy about it. It's $1,300 out of each of those providers' pockets that year. But that means there's only $4,000 to pay my practice. And my practice is much, much bigger. So that $4,000 positive adjustment, right? It's not 4%. For me, it's 0.4% for me. And it's only $133 per clinician. That's not much of a positive adjustment. And that's why you see the government use the word that says it's going to be a, quote, small positive adjustment or a moderate positive adjustment. That's what's going to happen in 2017. They have lowered the bar so low and made that so easy to avoid the negative adjustment. There are not going to be very many people that make that mistake. On average, we expect that will cost about $3,000 per clinician for the people who receive a 0 on their score. The performance threshold for 2017 is 3. If your MIPS score is 3, that means you've done one of those activities, one of those quality measures. You did the base measures for advancing clinical information. You did the bare minimum to avoid the negative adjustment. You'll have no negative adjustment. The majority of the people will be somewhere between 3 and 70, right? 3 will be the people who do the bare minimum. Anybody who does anything more than that will be scored, right? But you'll have to participate for a full year if you want to get above the 70. So we expect for most people the average positive adjustment for people who choose to participate fully in MIPS for at least 90 days will be about $351. So as you're making this decision, as you're trying to figure out what you want to do for next year, it's not about the money. Yes, there will be some people who score better than a 70, and the reason their number is going to be a bit higher is because they are tapping into some of those bonus dollars that the government has made available for the first 6 years of MIPS, right? But most people are going to fit into that middle category, and that's why the dollars are so small. So here are your choices. Here's what it looks like. If you want to do nothing, 0 points in MIPS, minus 4% adjustment next year. It's about $3,000 per clinician, right? If you want to do just the minimum, you'll have no negative adjustment, and that's a very, very low bar. We talked about what that looks like, right? If you're ready to go on January 1st and can do full MIPS for the full year and can score over 70 points by doing 6 quality measures and the improvement activities and the advancing clinical information measures and do all of those well, you may be able to qualify for a larger adjustment, right? If you want to do it for at least 90 days and do full MIPS, it'll be a very small positive adjustment, but you've got more flexibility here. You don't have to do everything. You can pick and choose. The more you choose to do and the better you do it, the more points you'll get and the larger your positive adjustment might be, but it's going to require some more effort. And so you have to think about that strategically. It's not just about the dollars. Part of it is laying the groundwork for what I might have to do in 2018. And some people will want to do that next year, and some people will say, you know what, I'm tired of all the government regulation. I'm tired of all the change. My doctors are tired of all the change. I get it. I just want to make sure that everybody is thinking about that strategically. Okay? I know we're running out of time. I'm going to launch this last poll question. The last one we've got is, what do you think? Where do you think your practice will land for next year? You think you'll be ready to go January 1 and you're going to participate for the entire year? You think you may do a shorter 90-day period, but try to get more points, try to get more practice in? Or do you think you might make the minimum effort to get the negative adjustment? You know, where are you going to fit? Great news, I don't see anybody that is saying that they're going to do nothing. It is an easy hurdle to cross, and I hope we have communicated that to you today. It's about even. We got about 40% saying they'll do it for 90 days, 40% for the full year, and 20% saying that they'll avoid the negative adjustment. I expect that's probably what you'll see in the rest of the market as well, but it's kind of helpful to be thinking about what other practices are doing as you make your strategic decision on what you want to do for MIPS next year. Whew, we went through a lot. We did it quickly. Here's what I hope you'll take away. Many of the changes that the government's making is helpful. We're making good progress, right? This is not as hard as it used to be. You should be able to avoid that negative adjustment next year. It's not hard to do. But I want you to think strategically about your level of participation. What makes sense for you? What makes sense for your doctors? How do you want to do that? And also, think strategically about your diagnosis coding, right? You are sharing some very valuable data with the payers, with the government. They are using that to measure cost and quality, which are going to be big parts of MIPS going forward. So make sure that you think about that as well. Thank you, thank you, thank you for your time today. I'm going to put my contact information here. If there's ever anything that I can help you with, please feel free to ask. I'm happy to do that anytime that I can. What I'm going to do is I'm going to stick around and try to answer as many questions as I can. If you need to drop off, feel free. But if you'd like a link to the recorded version, let me know in the questions panel. We'll get that to you. If you had trouble, some of you had trouble downloading the slides. If you had trouble with that, let me know. We'll send that to you via email. If you'd like the Excel report that I mentioned, that was on, has a list of all the quality measures, the improvement activities, and the ACI requirements. Happy to share that as well. Again, just let me know. Thank you for your time. Please, please, please spend 30 seconds and answer those survey questions. That feedback is extremely helpful for me, and nobody sees that except for me. So thank you again. Let me